Thanks to the COVID-19 pandemic and fewer people on our roadways, you would think the number of fatalities would also decline. But when it comes to impaired driving deaths in our state, just the opposite has happened. A preliminary look at the 2020 numbers from the Texas Department of Transportation reveal that motor vehicle crashes and fatalities caused by impaired drivers has actually increased by more than 7%. The Texas A&M Transportation Institute has recognized that prosecutors hold great power in preventing further impaired driving deaths in our state. That's why TTI created this training. The prosecutor training on the treatment and referral services for the impaired driver in Texas is sponsored by the Texas Governor's Office. It's designed to give prosecutors knowledge and skills and help them understand how DWI offenders' mental health might impact their decision to drive impaired. This training is divided into sections. We'll first discuss the impaired driving problem, then do an overview of the criminal activity literature. One section will discuss mental health and substance use disorder concepts. The next step is to explore applications of psychological information in legal settings. We'll close the training by sharing a few mental health resources that might be available in your community and investigate examples of criminal justice best practices. Thank you for being here and taking part in this training.
So, thank you all for joining us today. So my name is Courtney Hernser, and I work for the Center for Alcohol and Drug Education Studies, which is one of the many departments within the Texas A&M Transportation Institute. So our center's purpose is to be a positive force in eliminating driving crashes and fatalities in our Texas roadways. And we conduct research and outreach activities to try to understand how those crashes are caused. This training is only possible because of a grant from the state of Texas Governor's Office. Okay, so let's get started. So on this slide, you'll see probably just, you probably already know this information, but the Texas definition of impairment includes both a per se level of alcohol and a more subjective analysis of what normal use of mental and physical faculties means. Next, we're going to take a look at the snapshot of the impaired driving problem. So when we say DWI all, we're referring to motor vehicle crashes and fatalities that occurred in the public roadways in which the driver was impaired under the influence of alcohol, illegal, or legal drugs. And as you can see, impaired driving crashes and fatalities has remained a consistent problem based on this data for the last 5 years. Just as a disclosure, this information was obtained by a direct data request with TxDOT from their reportable data collected from the Texas Peace Officers Crash Reports, or the CR3, and it was received and processed by the department as of April 27th, 2021. Since TxDOT's database is a live one, these numbers are no longer up to date as of today's presentation. So the cost of impaired driving to Texas. This map illustrates the economic impact of impaired driving crashes in Texas. TxDOT had a number close to $11 billion in economic loss caused by alcohol-impaired driving crashes in Texas. And economic loss includes lost productivity, medical costs, legal and court costs, emergency service costs like EMS, insurance administration costs, congestion costs, property damage, and workplace losses. Not only are there economic losses, but there are also societal losses as well. And societal losses can include quality of life valuation, lost productivity experienced by an individual and others when a victim dies prematurely or experiences a shorter long-term disability, higher insurance premiums, and diversion of medical resources away from other medical needs. So we're not just looking at motor vehicle crashes and fatalities. We're counting that this crime also involves families, societies, and it has economic costs. And many people do report or self-report that they drive impaired multiple times a year. As one would expect, a great number of crashes occur in or around our metropolitan areas. So you would guess that, in Houston, San Antonio, Austin, those larger cities, we would see the greater number of deaths occurring. And while that is an important statistic, We also need to understand that the areas in the state that have a high traffic fatality amount based on their population size. Now, surprisingly, Dallas is the only big city that matches the expected statistic. The other 4 cities with the highest impaired driving fatality rates per 10,000 population are actually not in the top 5 for most populated cities in Texas. So we that kind of begs the question, why do some cities have higher fatality rates per 10,000 population than others? So today we're going to discuss one possible reason among many. And this training will point to the answer to that question, saying, it's a little more complicated than it seems. So as you can see, an average drunk driver has driven over 80 times before their first arrest. And there's been other studies that have indicated numbers as high as 200 times before their first arrest. And even in rural areas, that number can be even higher. So these are self-reported numbers, and people tend to even minimize their responses when they do self-report. They also do not account for polydrug use, which is becoming a more prevailing picture in our roadways. When talking about polydrug use, sadly, the research on impairing effects of various drugs are still in the beginning stages. So there's no per se levels of impairment for various drugs, as there are many factors that would affect such data. The state has toxicology labs that are experiencing log backlogs for testing. Most of our field officers are still not quite trained to detect drug impairment, and our laws are not yet set up to deal with drug cases as much as they've been set up for alcohol cases. On top of all that, we also don't have a statewide database to track how many original offenses correspond to actual convictions, because we have a lot of pretrial diversion programs and expungement laws. So what does all that mean when you put it together? The state doesn't have a clear picture of kind of how big the problem is. So kind of begs another question. Do most people get arrested by DWI self-correct, or do they get better at not getting caught? So the national recidivism rate in 2014 for folks who were arrested for DWIs repeatedly was around 25%. We are aware that the majority of crashes and fatalities are caused by the recidivists. It's important to spot this group and find ways to keep them and the community safe. Now in Texas, we have a higher rearrest DWI recidivism rate than the national average. So we're at 33% according to the Texas Department of Public Safety. So next we're going to look at the DWI defendants' profiles to paint a picture for you guys. So the profile of a DWI offender is complex. As you can see, previous studies have reported that a great chunk of first-time drivers present co-occurring problems. That can mean that they might have issues with multiple substances, or they might have a substance and a mental health problem manifesting simultaneously. So we don't know at face value if the person showing up in front of you is one of those who did it once and will self-correct, or if it's one of those who may have driven 200 times impaired prior to being seen by you already. Other studies have measured if repeat DWI offenders differ from first-time offenders or non-offenders on their levels of substance use disorders. One of these studies used the Alcohol Use Disorders Identification Test, or the audit. And the researchers found that just by looking at the test results, they could not differentiate between the first-time and repeat offenders in this sample. Both DWI groups scored higher on the audit test compared with non-offenders. So in other words, recidivists don't necessarily drink more heavily than first-timers, but a greater number of them seem to think more often about alcohol and have a greater emotional attachment with acquiring the drug. So these studies point to the finding that a person might feel the compulsion to drink in unfavorable contexts, such as when the driver had not intended to drink or had planned to drive. So as such, these characteristics might explain why this group continues to drink and drive in spite of the consequences. Okay, so now we're going to take a look at some of the literature we have in place. So researchers came up with the risk, needs, responsivity model, and it's still being used today. This model addresses 3 core principles. 1, Who should receive specific levels of services and supervision? So that would be the risk level. 2, what social and clinical factors should be addressed? So the needs principle defines what to target for each individual. And then 3, how to maximize the effectiveness of those services. So this is part of the responsivity principle. So I'm sure you've heard of these concepts during other trainings before, but I did want to highlight a few points about the model that often get misinterpreted. So the risk principle does not necessarily indicate a risk for violence or dangerousness. It matches the level of service, like supervision or treatment, to the level of risk of a person to reoffend. So in fact, the higher the risk level, the more intensive the supervision and accountability for that individual. So basically, the risk assessments are matching the intensity of the individual's intervention to avoid the reoffending, which speaks to the level of supervision needed. The needs principle points towards a need for further assessment. Okay, so now we're going to talk about the theoretical framework of criminal conduct. So Dr. Andrews and Monta in 2010 acknowledged that criminal behavior can vary depending on the individual's cost-benefit analysis of choosing between criminal or non-criminal actions. As these criminogenic factors play a significant role in recidivism, and the criminal justice system needs to take proactive steps to identify them. So, in an added note, these are criminogenic factors for the criminal justice population in general. The DWI population usually has a few more risk factors associated with them, such as high BAC levels at the time of arrest, previous traffic violations, and then a DWI history as well. So what are some crucial non-criminogenic factors that should be addressed? So there's motivation, treatment readiness, if there's a history of trauma, personal strengths and aspirations, and mental illness. To not address a person's responsivity factors can decrease that person's level of engagement, thus diminishing the outcomes throughout their involvement with the criminal justice system. Now, from the R&R model, the risk and needs matrix emerges. So as you can see, individuals can be placed into one of 4 quadrants. In the quadrant 1, which is the top left, we see high risk and high need. These are the individuals who usually have many clinical needs and may present as a risk of reoffending. So these are usually candidates for DWI, drug, and mental health courts. This group does need a lot of supervision, accountability, clinical, and wraparound services. In quadrant 2, in the top right, we see low risk and high need. So they do need more intervention, like the treatment and the wraparound services, but maybe not as much supervision. This group is usually better off receiving services from the community and not from the criminal justice system. In quadrant 3, the bottom left is high risk and low need. These are individuals who would greatly benefit from cognitive restructure thinking programs. They tend to have the criminal thinking ingrained, but they may not need the treatment at all. But they may have other needs, such as housing or transportation. They need accountability, and so supervision is an important component for those in this quadrant. In quadrant 4, the bottom right, low risk and low need, they need prevention tools such as DWI education and will likely not commit another offense again. They are most suited for a regular jail sentence or probation supervision with not much supervision needed. And so why does this matter? Mixing and matching will increase recidivism. Just like providing treatment to people who don't need it, it might make them worse. You shouldn't mix people of different risks into the same caseload. So why does this matter to you as a prosecutor? Screening defendants and knowing in which quadrant a person might fall in can help in the decision-making process and inform your judgment. So painting a picture of the chronic DWI defendant looks like we usually come up with a white male between the ages of 30 and 45 years old. is employed, and may have a lower education. These profiles inform the creation of DWI validated screening and assessment tools. So we have interviewed and surveyed prosecutors across the state and found that a great number of you have the ability to request screenings of DWI defendants as needed, or it is even a standard procedure to screen all DWI defendants in your office. Because of these findings, I'd like to point out a few points about the screening procedures. First, the Substance Abuse and Mental Health Services Administration, or SAMHSA's, definition of screening is a process for evaluating the possible presence of a particular problem, and it is quick, can be done with little to no supervision. And so then assessments define the nature of that problem, defines a diagnosis, and develops specific treatment recommendations. It is important to point out that the way correctional professionals use risk screening and assessments is to understand the likelihood of reoffending, while clinicians use screeners to identify mental health related needs and develop an action plan to tackle them. So in the slide, you can see the risk needs and tools that have been normed in the impaired driving population. And these are supported by the National Drug Court Institute and the National Center for DWI Courts. So the computerized assessment and referral system, or CARS, and the impaired driving assessment, the IDA, are the top two recommendations for these organizations. So even though the IDA is called an assessment, it is also a screening tool. They both usually take 30 minutes and are free. So why does using a DWI validated screening tool matter? Probation conducts screening that do a great job of assessing risk in general, but when it's used in the DWI population, non-DWI screening tools tend to score about 20% of DWI defendants as low risk, which will end up placing them on the wrong track for intervention and supervision. So this step matters because screenings are the initial step in determining whether an individual needs further evaluation for mental health or substance use disorders, which may in turn influence the recidivism rates. These brief evaluations help uncover any problematic signs that an individual should go through, or that an individual should go through a more comprehensive clinical assessment to determine the level of service needed. It will also more accurately point to the risk level of reoffending, given that the profile of DWI defendants is slightly different from the profile of an average justice-involved individual. The goal is to reduce the amount of people who will likely commit another crime. So accurate identification is the first step in sending people to the right direction. All this to say that you have the power to influence the accuracy of the information you receive from other criminal justice professionals to help you better identify DWI defendants' risks and needs, as you are hyper aware that impaired driving tends to be a symptom of a larger problem. So that is why we decided to bring this training to you today. We wanted to expose you to a wealth of information that will hopefully help you more easily deal with folks that struggle with clinical needs and they need more than just a minimal regular jail sentence or probation supervision agreement or sentencing. We're talking about individuals that will continue to drive despite the consequences. So we will shift gears and focus on understanding what are some of the things that these individuals might be experiencing that might lead to that risky behavior. We will talk about common mental health and substance use issues that DWI defendants suffer in general to gain a better understanding and how to consider those elements during the charging process and how to help individuals with those profiles. So that is why I am going to pass the baton over to Dr. Norrell Charles. Dr. Charles is a licensed psychologist and associate professor and director of the Clinical Psychology PhD program at the University of Southern Mississippi. She is our subject matter expert in all mental health related topics, and we are grateful to have her be a part of this training. So without further ado, I will let Dr. Charles take over.
So as Courtney mentioned, I'm a faculty member in a psychology program in Mississippi now, but I did my graduate training at Texas A&M, where I, as a graduate student, provided clinical mental health services in 2 different probation departments. And I also did my postdoc in Texas. So I have a lot of Texas experience, some of which did involve justice-involved folks. So I am happy to be speaking with you today. As Courtney mentioned, we will be hold on, let me grab my controls because they didn't immediately show up. I will be going over some definitions for mental health and substance use disorders so that you can better understand the specifics of what folks that you are working with may be dealing with and kind of know what you're looking for. So I'm going to first cover mental health disorders, then I will cover substance use disorders, and then there's a few kind of special topics areas that I will give you some information on as well. First off, just so that everyone kind of understands the prevalence of these difficulties, they are fairly common in the general population. Surveys show that 20% of adults in the US have a current mental health disorder at any given time. Now, a lot of those folks are not severely impaired by this. You may know people in your life who are dealing with anxiety or depression, but are, able to work and able to have a pretty typical life, even though they are dealing with some of those symptoms. There are some folks who have serious mental illnesses. Those are things where it's going to be much harder for them to function appropriately in society, and they may be more at risk for negative outcomes, including justice involvement. That's about 5% of the population. So it's still a decent number of folks, but not as many as who just more broadly experience mental health issues. About 8% of the US population has a current substance use disorder. So that's folks who are actively using and having consequences related to that use. And about 4% have both a mental health diagnosis and a substance use disorder at the same time. Those folks are particularly at risk for negative outcomes because they are dealing with more than one different kind of problem. Among folks who are involved in the justice system, rates of mental health issues are much higher than they are for folks who are not involved in the justice system. The majority of people who are incarcerated do have a mental health disorder or a substance use disorder. About 25% do report being physically or sexually abused in the past. And the most common disorders in this group are depression, which is also very common just in the general population, and then a couple of those more severe mental illnesses, bipolar disorder and psychosis. And I will go through a little description about what each of those are so that everybody recognizes what they are. More than half of folks in the justice system report substance misuse. Among those who have a mental health disorder, which is again a majority, it is more than 75% who also have a substance use disorder. So lots of folks with those co-occurring conditions that can be more troubling. About 20% of offenses can be directly related to someone's psychological problems. So for example, because of the symptoms they were having, they behaved in a way that was harmful to somebody or in some other way was illegal. And so we can say that in a significant portion of these arrests and these criminal activity situations, that some of that is directly related to mental health type issues. But of course, the majority is not. They may be people who still made those decisions to engage in criminal behavior, but it's not directly a result of their psychological problems. So first off, some definitions for mental health disorders. Overall, a mental health disorder, broadly speaking, is a pattern of emotions, behaviors, and or thoughts that are inappropriate to the situation the person is in and lead to distress and or impairment in life. These are generally thought to result from an interaction of a variety of different things. There are biological risk factors, brain-related differences, social experiences, and life history things that make someone more vulnerable to developing a mental health disorder. The types of symptoms that we see in mental health disorders fall into a few different categories. In the cognitive area, this is stuff related to your thinking processes. So having trouble remembering things, having trouble concentrating, those can be symptoms of a mental health disorder. On the physical side, we'll see folks have elevated levels of fatigue, muscle tension, and sometimes things like an upset stomach. On the emotional side, examples would be feeling sad a lot of the time or panicking and having these panic attack kind of things that I will describe in a little more detail in a few minutes. And then behaviorally, we see symptoms like aggression at times and odd or erratic behaviors that may lead someone to be involved in the justice system. The development of mental health disorders, as I mentioned, comes from a few different places. On the biological side, for a lot of disorders, there is evidence that a family history of that disorder, like if one of your parents has it or another close relative, makes you more likely to develop that disorder. So there's some kind of genetic piece there. And that is true in some cases when you are raised by that person, and in some cases even when you're not raised by that parent that has that disorder. So there does seem to be a genetic component. It's not just kind of learning type things. The differences in genes or in the chemicals in your brain based on your genes do lead some folks to be more vulnerable to certain kinds of disorders than others. On the environmental side, exposure to significant stressors or traumatic events can lead to the development of a mental health disorder, as can problems in family functioning, both during childhood, but also just currently in their family situation with adults. The age of onset for mental health disorders varies by the type of disorder. So for behavioral problems, something like ADHD, typically that shows up in childhood. For something like psychosis, that's usually in adolescence or early adulthood when that first starts to happen. Mood disorders are most commonly diagnosed in adults, but they can start earlier in life. And anxiety disorders happen across the lifespan. So getting into some of the specific disorders, I'm sure folks have heard of depression. So the clinical term for significant depression is major depressive disorder. And that means 2 or more weeks of depressed moods, feelings of worthlessness, not being able to sleep very well or sleeping a lot more than normal, changes in eating patterns, poor energy levels, and diminished interest in or enjoyment of a lot of activities. So not wanting to socialize, not being able to enjoy hobbies, things like that. The person is kind of just pulled back from life a little bit when they're depressed. So this is different from something like grief, where there's an identified loss that someone is dealing with, and that is a normal human process. This would be coming kind of out of nowhere, like they just suddenly start to feel this way and there isn't some obvious reason for it. It's also different from just typical sadness. So everybody has times when they're feeling a little more blue, or they're not really in a good mood. But if it's not this 2 weeks or longer of these kind of intense depressive symptoms, it's probably not major depressive disorder. Major depressive disorder can cause as much impairment as physical health problems when we look at things like days missed of work, impairment in relationships, things like that. So it is something that can really impact somebody's life, even though it is unfortunately a fairly common disorder. There does seem to be some biological vulnerability to developing depression. So we see things like it running in families, and it can be a chronic lifelong condition, but we do have treatments for major depressive disorder. So someone being on an antidepressant medication and or in therapy for depression can help them get over this disorder and not have it be a chronic condition for them. Another disorder that is in the same category of mood disorders, because it involves mood, is bipolar disorder. This is when someone alternates between feeling depressed, like on the previous screen, and then something called mania or hypomania. Mania is the more severe version, hypomania is a less severe version, but it's the same kind of symptoms. So these folks will have these periods where they're feeling really depressed and they kind of look like the previous slide. They'll have periods where they're neither depressed nor manic, and then they'll have periods where they're manic. And when they're manic, that is when they have an excessively kind of up mood. So they're overly cheerful, overly excitable. They don't need to sleep as much. So in depression, they might not be sleeping well, but they'll feel tired. In mania, they won't feel like they really need to sleep. They'll sleep 3 or 4 hours a night and have all the energy in the world. They'll be more active typically, so they may start projects. They may be more social during this time. They're going to be distractible, have trouble concentrating, and will have this experience called racing thoughts, which is basically like your brain is fast forwarding on you. You just have this constant information coming through your mind. It also may be noticeable to other people that they have what's called pressured speech. So that is when they are like speaking really quickly and kind of not letting you get a word in and just going and going and going. And it's like they kind of can't stop talking. These periods of mania or hypomania do need to last for days at a time. So it's not that someone just is, extra cheerful one afternoon. This would be multiple days in a row where they are not sleeping, they're distractible, they're talking too much, they're acting kind of strangely sometimes. Bipolar disorder has a strong biological basis. So again, we see this running in families. We don't totally understand the origin of a lot of these disorders still, but there have been studies looking at figuring out what kinds of genetic background lends someone to developing bipolar disorder. Bipolar disorder is typically a chronic and lifelong condition. It sometimes does get better with age. We see folks in middle adulthood and older adulthood having milder symptoms than they did when they were younger. And it can cause a lot of impairment, but not necessarily. So it can be managed, just like with depression. But if it's not managed very well, we will see things like the folks will have trouble, keeping a job because of these changes in mood that lead to some erratic behaviors. They may engage in high risk behaviors. So when they're manic, there may be substance use that happens that can compound the symptoms. They may engage in risky sexual behavior, gambling, other kinds of things that are poor decisions that they're making when they're not really thinking clearly and they're kind of overly excited. Bipolar disorder is usually managed with medication. As I mentioned, it has a strong biological background, and we do need a biological treatment often to really help people with this disorder, so medication comes in there. But therapy can also be helpful in getting people to recognize the signs that their mood is changing and having some skills to cope with the symptoms. Anxiety is a different category of disorder. So this is when someone has distressing, persistent anxiety or maladaptive behaviors, so behaviors that don't work very well, that they do to try to reduce their anxiety. So everybody has a little bit of anxiety, right? So maybe, before you have a big court case or before you have to give a speech at a convention or something, you feel a little bit of anxiety. That's normal. Anxiety disorders are when someone has chronic, intense anxiety that interferes with their life. So a few examples of disorders are generalized anxiety disorder. This is when someone has persistent tension and worries a lot of the time about all kinds of things. So everybody worries a little bit, but this would be very chronic worrying about things, including things that are very out of your control, like, whether you are going to be a good parent before you even are married or have any children, things that are way in the future that you don't need to be worrying about right now, but can't stop worrying about. Another disorder is panic attacks. So this is episodes where someone has this discrete 10, 20-minute period where all of a sudden they are flooded with a feeling of panic. It often comes out of nowhere. It can be triggered by certain things, like if someone has a strong fear, a phobia, like I'll talk about in a second. But the diagnosis of panic disorder is part of that is that they come out of nowhere. So somebody's walking through the grocery store and all of a sudden they feel their heart racing, they feel intensely scared and freaked out. They may think they're having some kind of medical episode because they feel physically off too. And then it'll resolve in 10 or 20 minutes. A phobia is a persistent fear of some kind of object or some situation. So for example, someone who is very afraid of being in small spaces, who because of that cannot take an elevator to get to an appointment because the elevator is too small of a space for them. And so that's kind of impairing their ability to do things because they will get very intensely scared if they have to go in an elevator, but they need to do it for whatever reason. Obsessive compulsive disorder is a little bit different. This is where those maladaptive behaviors parts comes in the most. This is when someone has unwanted repetitive thoughts or actions, things that are coming through their head that they do not want and kind of can't control. The thoughts often are troubling things like violent images or sexual images that bother the person, and they engage in these maladaptive behaviors to try to make the thoughts go away. So for example, they will have to wash their hands a certain number of times, or they will have to flick the light switch a certain number of times. And if they go through that ritual enough times, the thought goes away and it becomes this kind of reinforcing cycle where they have these thoughts that bother them. And then they also engage in these kind of time-consuming behaviors that are not really in the long run going to be helpful for them. Anxiety disorders are less biologically based than the mood disorders are. They can all be treated with medication, and they can also be treated effectively with therapy and no medication. So people have options as far as their treatment for anxiety. One disorder that involves anxiety but is kind of in its own category is post-traumatic stress disorder, which I'm sure folks have heard about. So this is what happens when someone experiences a traumatic event and then has symptoms afterwards that go on for a long time and become impairing. Symptoms would be things like intrusive thoughts. So like in OCD, they may have memories of the event, they have stuff pop into their head, but it's all related to their traumatic event. It's not random kinds of worries. They may also have nightmares about what happened or flashbacks to the event. They may avoid things that remind them of the traumatic event. So for example, sometimes you hear about veterans being really uncomfortable with fireworks shows because the explosions remind them of some of their combat experiences. So, feeling like you cannot attend a family event that involves fireworks because it reminds you of your traumatic event, that would be an example of avoidance. Folks may also see changes in emotional and behavioral functioning. So they may have mood difficulties like in some of the other disorders. They may be irritable with their family. They may feel like it is hard for them to hold down a job or to do other things that they kind of need to do in their daily life. PTSD was first documented among war veterans like 80 years ago, but it can occur in response to many types of events. So someone who was in a bad car wreck, someone who was sexually assaulted, those are also potential ways that someone could develop PTSD. It is required for the diagnosis that there is some major traumatic event. So unlike some of the other disorders, PTSD is not something that someone just develops at some point in their life, one day they have it. There does need to be a traumatic event. But people vary in terms of their biological vulnerability to PTSD specifically. So we'll see, for example, using the combat experience, 2 veterans might be in a IED explosion situation. But based on their biological makeup, one of them may go on to develop PTSD and one of them may not. So they had the exact same traumatic event, but they're different people, their brains work a little differently, so they're going to have different stress responses to that. PTSD can be treated with therapy, and that's really the first line recommendation, is that there's therapy to cope with the traumatic event, process what happened, and develop skills to move forward in a positive way. Medication may be helpful, but the primary recommendation is for therapy. Schizophrenia is another one of the more severe disorders, like bipolar disorder. It's not super common, but it is very impairing for folks. The symptoms of schizophrenia are things like disorganized and delusional thinking. So this is where they're not thinking clearly, they're not making a lot of sense in terms of connections they're making or things they're trying to explain. And they may be delusional, which means that they have ideas that are not based in reality. So for example, the CIA is following them and spying on them, or their neighbor is trying to poison them. Things that are kind of paranoid a lot of times, although there can be other kinds of delusions, and don't seem to be really realistic ideas, but they're very committed to them. They also typically have disturbed perceptions, so that's hallucinations. They are seeing things, hearing things, sometimes physically feeling things that are not really happening for other people. They also often have inappropriate emotions and actions. So like their mood may not be appropriate for the setting they're in. They may be like really excited and happy during a funeral, for example. And their actions may also be odd, like they're not dressed appropriately for the weather, or they're behaving in a strange way in a public setting. Schizophrenia has a very strong biological basis. It does run in families, and we do think that there is a genetic basis for this, even though that has not been totally figured out. Schizophrenia is a lifelong disorder. It is not something that will go away on its own, and medication is usually needed to treat the more intense symptoms, things like hallucinations and these delusions about people trying to harm them or whatever their specific delusions are. There are other types of psychosis other than schizophrenia. So psychosis is those symptoms like the delusions and hallucinations. And when you have schizophrenia, you typically have that, but you can get it through other things too. So people who are psychotic are thinking and behaving in ways that are not connected to reality. They are likely to be impaired in multiple life domains. It's going to be hard to hold down a job. It's going to be hard to take care of your children and do other things effectively if you have these really intense psychological symptoms. They also may be difficult to reason with or to control if you're trying to work with them in some kind of professional capacity. The other types of psychosis that people get are, number one, brief psychosis. So that is basically a stress reaction. If someone has a significant stressor in their life that they're not managing very well, not necessarily PTSD type stuff, so they can certainly have a traumatic reaction and not be psychotic, but other kinds of things, major financial problems, family problems, can lead someone to briefly have a psychotic episode. And that typically is something that goes away. That is not going to be a lifelong condition if it's not based in something like schizophrenia. It's just, in the meantime, they've had something very stressful happen to them and their mind has just kind of broken up for a little bit. There is also postpartum psychosis. So this is when after a woman gives birth, she has psychological symptoms based on all the kind of physical changes that have happened to her. Folks have probably heard of postpartum depression. Psychosis is less common, but obviously it can be very serious and it can lead women to do things like harm their infants. If a woman has postpartum psychosis, it's likely to resolve once her hormones get rebalanced and she gets treated and not be a lifelong thing for her. However, if she's had it once with one birth, she is likely to experience it again with subsequent births. So it is something to be aware of if this is in someone's history. Then there is also medication or substance-induced psychosis. So there may be folks where they've had a medication interaction or they've taken an illicit drug that has led them to look like they have psychotic symptoms, but really it is related to that substance that's in their system. And once that washes out, they're not going to be psychotic anymore. So now I'm going to cover substance use disorders. So this is still under the umbrella of mental health difficulties, but these are the substance-specific ones. A general definition for a substance use disorder is a problematic pattern of use of a substance that impairs that person's functioning. To make a diagnosis, we look for 2 or more of the things on the screen within a 1-year period. So failure to meet obligations, like are they missing work because of their use? Are they using in physically hazardous ways, like while driving, for example? Is their use causing problems in their relationships or other areas of their life, but they're continuing to use that substance? Do they have a physical tolerance for the substance, like they're needing to use more to get the same effect? Are they having a lack of control over their use, like they say they're just going to have 1 drink, but then they have 5? Are they not able to cut back or stop using their substance? Do they reduce other activities, like they're not as social or not engaging in hobbies they used to because of their use kind of taking over a lot of their time? And do they have strong cravings for using that substance so that it's hard for them to kind of resist or cut down significantly? When we make substance use diagnoses, we use that criteria for any substance the person is using. So it is not that if you're using a substance, multiple substances potentially, you do not necessarily have a substance use disorder for any of those. But if you have a single substance for which you have at least 2 of those criteria met, you have a disorder related to your use of that specific substance. Substance use disorders are specified as being either mild, moderate, or severe in their current status, and that has to do with how many of those criteria the person has. Like I said, they only need 2 to meet criteria for any disorder, but they obviously could have more than 2. So someone who's got 6 of those has a more severe diagnosis than someone who just meets criteria at having 2 of those problems. You may also see on someone's diagnosis that they are listed as being in remission. This means that they have not had those criteria met for a period of time. In early remission, that's just 3 months where they have not had any of those things be true for them. In sustained remission, it's for a whole year. And that distinction is made because folks are more likely to relapse and have continued problems when they are earlier in their remission process than when they are later. So if someone's in early remission, that is great, but they are still at risk of having problems. If they're in sustained remission, they've been able to go a whole year without having those problems, and they're more likely to be able to stay in that situation. Substance use disorders develop like other mental health disorders for a variety of reasons. We do know that there are some biological risk factors. Someone who has a parent with a substance use disorder is at least 4 times more likely to develop their own substance use disorder. This is true even when that parent did not raise them. So it's not necessarily that they got exposed to a lot of use in their household or anything. It seems to be a more genetic thing. There are also environmental risk factors. Things like their peer group and how much substance use is common in that group. Do their friends go out to bars a lot? Do they smoke a lot of marijuana? They're more likely to develop a disorder when that's kind of their peer situation. Exposure to stress and trauma can also lead to the development of substance use disorders, as can difficulty regulating their own emotions. Some people find that drinking alcohol, for example, makes them less anxious, or using other substances may help them manage emotional issues or mental health disorder symptoms that they have otherwise. It is not obviously the healthiest way to manage those kinds of symptoms, but it does sometimes work for people. And when they are using alcohol or other drugs to try to manage their psychological difficulties, they're more likely to ultimately develop a substance use disorder as well. The age of onset for substance use disorders is typically adolescence through mid-adulthood. It's not something we see obviously in children very much, and it's not something that usually develops later in life. It's something that is in somewhere in the teens, 20s, 30s kind of range. The first use age for people who go on to develop a substance use disorder is typically in mid-adolescence. So they don't necessarily have a disorder at that point, but if they're using in high school, they are more likely to go on to develop a substance use disorder. A couple of facts about substance use disorders. So alcohol is the most commonly used substance in the US, which makes sense, right? It's legal in every state. And about 29%, so almost a third of adults in the US will meet criteria for alcohol use disorder in their lifetime. Not necessarily all right at this moment, but throughout the course of their life, a number of adults in the US will have an alcohol use problem. About half of those will have what's considered a severe alcohol use disorder, meaning that they have a high number of those criteria I presented a couple slides ago, where they have multiple life problems and physical difficulties and things like that as a result of their use. About 10% of the population will meet criteria for another substance. Cannabis is the most commonly misused substance outside of alcohol and the most common disorder diagnosis, but obviously there can be others as well. Substance use disorders in general are about 50% more common in men. Certainly they can happen in women, they can happen in all kinds of age groups, but men in that kind of young adult to mid-adulthood kind of time frame are your most common substance use disorder patients. Substance use disorders can be chronic, but there are effective treatments. I'll talk a little bit about some relapse-related issues later on in this talk, but it is very common for folks to not be able to simply immediately stop using the substance and never have problems like that again. People do tend to have difficulty managing their substance use disorder for a long period of time, even with treatment. There are medications that can help for some substances, particularly opiates and alcohol, but for some substances, there isn't really a medical intervention that is helpful, and it's more of the behavioral, psychological kind of intervention that can help them get over this problem. And the way that works is that therapy will help the person address the reasons why they developed a substance use disorder in the first place. So were they trying to manage emotions that they didn't know how to handle in a healthier way? Did they have family problems that were kind of leading them to use a substance to try to cope? Helping them make changes in their life in a larger sense can help them change their behavior going forward and not feel like they need that substance as much. So now moving on into what I call special topics, so other kinds of related things that are, I think, useful for you to know. I mentioned early on that a lot of folks, about 4% of the population, do have what's called co-occurring disorders, which is when they have a mental health disorder and a substance use disorder at the same time. About 38% of people who have a substance use disorder also meet criteria for a mental health disorder, and 18% of people with a mental health disorder also have a substance use disorder. So there's a lot of overlap here. The reasons for that are that kind of self-medication that I've mentioned, where folks are maybe trying to manage the hallucinations that they're hearing or their manic episodes by using substances that help them regulate a little bit better. There's also just this concept of shared vulnerability, where if you are genetically or biologically predisposed to developing any of these disorders, you're probably also vulnerable to developing more than one of them. So there are reasons why people are developing more than one thing based on kind of their biological background and sometimes their environment or their family processes. Unfortunately, more than half of people in this country who have mental health and substance use disorders at the same time do not receive treatment for either of those conditions. The best practice for this, which I'll explain a little bit later on, is to treat both of those problems simultaneously, but fewer than 10% of the people who need that kind of treatment actually receive it. So this is a very undertreated group of folks who also have more severe problems than people who just have one disorder. There are also some medical disorders that can look like psychological problems, but really are not. So people with medical conditions can be aggressive and violent. They may be more impulsive while they're having that medical condition, and they can even engage in criminal behavior because of the medical problems they're having. Traumatic brain injury is one area where we see this happen a lot. Up to 70% of people who have a traumatic brain injury for whatever reason exhibit irritability, so they're sort of like cranky and difficult to deal with, and may become aggressive. Other things that sometimes look like psychological problems but are medical problems include infections in the brain, strokes, and certain kinds of degenerative diseases like Parkinson's disease that can bring on psychotic symptoms where they're hearing things that other people don't hear, for example, mood problems like being depressed, or behavioral problems like being aggressive, like I said. All of this stuff affects the brain. And so it's not that this person inherently had a psychological problem, but because of the difficulties and the things that are going on with their brain as a result of their medical problem, they may have some behavioral issues. Medications can also affect behavior. Like I mentioned a little bit ago, someone may be on a medication that causes them to have more irritability or to be more aggressive. And a lot of times that can be repaired by just adjusting the medications that the person is on. Developmental disorders are a category of mental health disorders where the person has limitations as far as their intellectual functioning in a lot of cases and life skills kinds of things. Looking at folks who are incarcerated, about 20% of prisoners and 30% of folks in local jails have a developmental disorder of one type or another. The most common of these is intellectual disability. This is what used to be called mental retardation. It is someone who has significant limitations in both their intellectual functioning, so their IQ, as well as everyday social and practical skills, so their ability to live independently, take care of their bills, things like that. This begins in childhood, so it must be something that was apparent basically through the entire person's life. It's not something that just comes on later in life. And the criteria are that their intellectual ability is in the bottom 5% of the population. So they have a very low IQ when tested relative to other folks, and also that they have these life skills kinds of difficulties. It's both of those things together. Autism is another developmental disorder that is less common in justice-involved folks than ID is, but it's still something that you may run into. This is when someone has deficits in their communication ability, their social skills, and their ability to behave in a socially expected way. Sometimes folks with autism do have intellectual deficits and low IQs like those with ID do, but not always. Sometimes they just have these other kinds of difficulties and their IQ is typical or even above average. Autism is found in about 1.5% of the population. It is more common in males than females, and it also typically begins early in childhood. As I mentioned, folks with intellectual disability are overrepresented in the justice-involved population. They tend to not have the best decision-making skills. They may be convinced by other people to engage in criminal activity because they're kind of not as savvy as some folks do and don't realize what isn't a good idea to get involved in. So that's some of the explanation there. With autism, these people are not especially likely to be violent or anything like that, but because they have difficulties with communication and social interaction, they do sometimes come into contact with the justice system because of things like stalking. They do not understand that their behavior is unwanted by the other person and is making them uncomfortable and is potentially criminal. There are some cultural factors that relate to how someone with a mental health or substance use disorder may present to you, may behave. Culture can influence things like what are the specific risk factors for someone developing a disorder. The types of symptoms that they experience may vary across different cultural groups. Their willingness to seek help may vary. We do see that in this country, a lot of communities of color and immigrant families also are kind of less common working with the medical system and seeking out help for emotional and behavioral issues. So they may be less comfortable if they're from a culture where that's not really an accepted thing and they may not be getting the treatment they need. The availability of treatments that are appropriate for folks from different cultural groups is also going to vary. So for example, if they can't find a therapist from the same cultural background as them, they may be less likely to be interested in treatment or to find it effective. If treatments aren't available in the language that is most comfortable for them, that's another barrier. And for some cultures, it is recommended that more family involvement happens in the therapy process, and that's not always a really available thing in a certain local community. It is still the case that mental health disorders and substance use disorders are universal. Anyone from any kind of cultural background can develop them, but it's important to just be aware that someone's cultural background and family background may differ in terms of like how they present. They may present differently, and their ability to get the help they need may vary. So if you're working with folks who are from a different cultural background than you are, or than what the majority is in your local area, you may have to contend with these factors. Another topic I want to cover is risk for suicide. Unfortunately, suicide is the leading cause of death in local jails currently, so it is a problem for justice-involved folks. Those who have been recently arrested and recently paroled are at increased risk for suicide relative to the rest of the population. And relevant to what we're talking about today, folks who have mental health difficulties are more likely to try to kill themselves than folks who do not have those difficulties. People with a substance use disorder are at least 10 times more likely to attempt suicide during their life. And autopsy results show that more than 20% of people who die by suicide were legally intoxicated at the time of their death. About half of people who die by suicide had a current mental health disorder in their medical records. And for those more severe disorders like schizophrenia and bipolar disorder, the risk of someone trying to harm themselves is much higher. And that has to do with those being particularly impairing conditions, probably, right? They are dealing with more intense symptoms. They're having more life difficulties. Their life is harder. So they are more likely to try to end it. Now, as a clinician, I am very used to folks having thoughts about harming themselves. That is something that is not at all uncommon in psychological practice. Every year, about 25% of people who think about harming themselves actually make a plan to do so. So the majority of people will think about it and talk to their counselor about it, but they're not actually making any steps. But 25% of them do. So we want to pay attention when someone is talking about suicide in case they are one of these people who starts to make a plan, like they obtain a weapon to do that, they start stockpiling their medication so they can overdose, things like that. About 10% of this population will make an actual attempt in a given year. So it goes from kind of thinking about it being kind of common, making a plan being less common, and actually attempting is even less common than that. Obviously, because people with mental health and substance use disorders are more likely to consider harming themselves, we need to kind of pay attention to what risk factors are and what we can do to try to help these folks. So steps that you or folks that you work with can do include providing people with suicide crisis line information, encourage them to use healthy coping skills and communicate with their loved ones to try to get support. You can try to restrict their access to common methods of suicide. Like, for example, if they're a firearm owner, can somebody else hold their firearm for a little while? If they're thinking of overdosing, can somebody else help give them their medication every day instead of them being in charge of the whole bottle? You can also certainly encourage treatment. So if they have depression or they have a substance use disorder, if they get into treatment for that, they're less likely to feel suicidal. And in some cases, it may be necessary for someone to be evaluated by a professional in a kind of crisis situation. So they may need to go to the emergency room or may need to talk to some kind of mental health professional pretty quickly if they're really actively thinking about harming themselves. So I mentioned crisis lines. There are multiple of these, but one is the National Suicide Prevention Lifeline. The number is on the screen. This is a 24/7 service that is available to anyone to talk about their suicidal thoughts. Things that you should be aware of are a defendant who is increasing their alcohol and drug use, that because there's an association between substance misuse and suicide, they're more likely to go through with the plan when they're intoxicated. So if they're using a lot more, they're at more risk. If they're behaving aggressively, that may also mean that they're kind of not controlling their behavior very well and they may harm themselves. If they are withdrawing from their friends, family, community, they stop going to social events, they stop going to church, things like that, that's a risk factor. If they're having really dramatic mood swings where they're really seeming kind of unstable and out of control with their emotions, they may impulsively harm themselves. And if they're doing other kinds of impulsive or reckless behavior, that also suggests that they're not in full control and they may harm themselves. On the right side of the screen are suicidal behaviors. So this is kind of an elevated warning sign where it looks like someone is really starting to make plans to leave this world. So that would be things like giving away possessions that are important to them, trying to tie up any loose ends in their life, like paying off their debts, getting things kind of set up, and then also even saying goodbye to friends and family. Folks may really go through talking to people and kind of indicating that they're going to harm themselves and that they're not going to be around anymore. And if someone is saying stuff like that, that really suggests they're far along that planning process and they need to get some help. So obviously, as prosecutors, you're also concerned about someone's risk for violence. And some of this stuff is similar to risk for suicide. Obviously, there are different behaviors, but some of that not being very regulated, not making good decisions does apply in both cases. A substance use disorder is associated with 25 to 35% more risk of lifetime violence. Mental health diagnoses are less closely associated with risk for violence, but those folks are still more likely than the general population to be violent. When you are assessing risk for violence, you want to think about a number of factors. So having a history of trauma, having a history of suicide attempts, and having a history of violence have all been associated with future violence. Someone may also be talking about their thoughts to harm someone or their plans to harm someone. Like, for example, they're very upset about the end of a romantic relationship and they're making comments about wanting to harm that person. Just like with suicide, if they are talking about wanting to do it or have any kind of plan to do it, they're more likely to actually do it. So you want to pay attention to things like that. If someone is also currently experiencing psychotic symptoms, like they're hearing things that other people don't hear, the voices may even be telling them to be violent, that is something that increases their risk for violence because they're really not making good decisions during that time. If they are also currently intoxicated, they are more likely to be violent than folks who are not intoxicated because, again, lowered inhibitions, bad decision making. Some background factors that are related to risk for violence include someone who has a lower IQ and someone who is of lower socioeconomic status. Having a history of being in mental health or substance use treatment and not complying with that treatment, not being successful in that, is also associated with future violence. having an environment that supports violence. So, if they're gang affiliated, for example, that increases the likelihood that they personally will be violent. And of course, access to weapons is a concern. If this is a firearm owner or someone who has a lot of knives or something like that, they're more likely to use it when they have access to it than folks that don't easily have access to weapons that can be harmful. In general, males are more likely to be violent than females, and young adults and teenagers are more likely to be violent than folks who are older than about 24. Obviously, anybody can be violent, but in terms of your general risk factors, that's the population you'd be most concerned about. So now I'm going to segue into talking about treatment for these kinds of disorders. So the overarching main type of treatment I would recommend if you are looking to refer a defendant to some sort of therapy in your community would be something called cognitive behavioral therapy. This is not one specific book that needs to be followed or anything like that, or one training protocol. It is an umbrella term for a variety of interventions that are focused on problematic ways of thinking and problematic ways of behaving. The idea is that cognitive behavioral therapy helps change cognition, so that's thoughts, as well as behaviors, because folks have learned ways that are not helping them thinking wise. They're distorting some things, or they're making bad decisions, and they can learn to better process information that's coming in, and they can learn how to change behaviors, patterns that they've learned that are not helping them and are causing them to get in trouble with the justice system or other kinds of problems in their life. We try to help them learn better ways of coping, ways to be more effective in their life, which will reduce any specific symptoms that they are having and also help them just overall be a better adjusted person. Research shows that CBT is as effective or more effective than other forms of therapy or medications for many disorders. So it is a really strong treatment that is the most evidence-based thing for most disorders. There are some cases where it is best to do therapy like CBT and a medication at the same time, but someone getting CBT alone is likely to have some positive outcomes because it is very effective for a variety of things. The way CBT works is we try to reduce symptoms through things like educating someone about their disorder so they can better kind of be prepared and manage things, know what to expect, learning skills that will help manage the symptoms that they have, and developing new ways to think about problems and solutions so that they are behaving in a healthier manner. CBT focuses on the present, what difficulties this person is having now, what kind of help they need right now. It is not lie on the couch and talk about your mother and your childhood. We are focused on what this person needs today. A lot of times a therapist will give the client homework. So in the therapy session, they may practice certain kinds of skills, and then they are told, okay, during the week before I see you next time, you need to do this on your own 2 times. So they get these little activities like that. So they are learning things in therapy, but they're also applying it to their life outside of therapy. Some examples of targets for a CBT therapist would be things like learning coping skills for anger and other emotions. A lot of people don't really know what to do with all their emotions. It's not something that people get taught really in school. And if your family didn't really teach you good coping skills, you may just have a deficit in that area. So it can help people to just learn better coping skills, and that way they won't react in ways that cause problems. We also sometimes teach relaxation techniques for things like anxiety, and we can teach communication skills to help folks have better relationships with their loved ones, as well as more effective communication at jobs and things like that. For substance use disorders, there are some specific kinds of treatments that are sometimes used. So detox is when someone goes into a medical setting to have a supervised withdrawal from their substance. And there are some substances like alcohol and opiates especially where it can be medically dangerous to just cold turkey stop using that substance. So in some cases, it is helpful for someone to go into a hospital with some trained medical staff to make sure that they can safely get off of the drug that they are on. Not every person with a substance use disorder needs this by far, but some do. Then after detox, or if they don't need detox, someone can be referred to inpatient or residential treatment, which is where someone goes and lives in a facility and gets treatment during that time. Or they can be referred to outpatient treatment, which can look like counseling for other kinds of difficulties, like once a week or every other week they go and talk to a therapist. Some people find self-help groups or 12-step groups like AA to be really useful in their recovery, so that's another possible type of treatment. And in some cases, folks do use medication, something like methadone for an opiate use disorder to help them stay clean. As far as the psychotherapy that can be recommended for substance use disorders, so CBT can still be helpful for this type of disorder, but there are some specific substance-related ones that may be useful if they're available in your community. One is called contingency management. That is where the therapist and the client create a list of rewards and punishments, essentially, for their therapy progress. So, for example, if they are testing negative on drug screens and they're abstinent for a certain period of time, then they get some benefit. Like if they're in a residential facility, they'll get more privileges than folks who are lower on the system and not getting as many rewards. This is a kind of partnership between the therapist and the client to figure out ways to help them make positive choices by rewarding things and giving them things that are more negative when they don't do well. And that's supposed to kind of increase their motivation and ability to stick with the program. Motivational enhancement or motivational interviewing is under this realm too. This is a usually early in the process treatment that if people are on the fence about whether they really need substance use disorder treatment. So the therapist may feel like, yes, this person has a substance use disorder, but the reality is if they don't really recognize that themselves, they're unlikely to get as much benefit out of the therapy process. So when we do motivational enhancement treatment, the therapist is non-judgmentally meeting with the client and just sort of talking about the situation. So tell me about the use, tell me about, what experiences and consequences and things like that you've had. And they're trying to lead the person to recognize on their own that they do have a substance use problem and that it is causing problems in their life. And then they will be more ready to benefit from a different therapy program once they've kind of gotten their motivation in the right place. This example is called 12-step facilitation. So this is where someone goes to 12-step meetings like AA or NA, and the therapist kind of coaches them and helps them get the most out of that process. So we're using both the 12 steps and the therapy to help this person. So I mentioned co-occurring disorders and the treatment needed for them previously. What is currently available in a lot of settings is one of the things on the screen here. So single model is when the primary disorder is treated effectively, the therapist thinks the client's substance use will resolve. So for example, somebody has PTSD, let's treat the PTSD, and then once they're not having PTSD symptoms, they won't be drinking as much because they're drinking to cope with PTSD. That may work for some people. There's also the sequential model, which is where these disorders get treated one at a time. So they go to treatment for PTSD and then they go to treatment for alcohol use disorder or vice versa. So that may work for some people to have it kind of separated out like that. The parallel model is when someone gets treatment at the same time for both disorders, but in different settings. So they're seeing an alcohol counselor in one area and they're seeing a PTSD counselor in another area. And those people are not necessarily talking to each other, but both things are getting treated technically. What is recommended for these folks is what's called integrated model of treatment. This is when there is a single treatment team at one facility that is treating both the substance use disorder and the mental health disorder, and they're communicating amongst themselves to give the most kind of comprehensive and detailed treatment for this individual person. And I worked on a treatment team like this when I was on my residency, and it was in a community mental health setting. There was a physician, there were social workers, there was me as a psychology trainee, and we were all kind of discussing these cases and the needs that came up on both the mental health side and the substance use side and treating the whole person. So this is the best thing that you can refer someone to if it's available. This model assumes that one disorder is not necessarily primary, that they have both problems and they both need treatment and they both need the same level of kind of care and attention. There may or may not be a causal relationship with the two disorders. So just because they have PTSD and alcohol use doesn't mean the PTSD caused the alcohol use problem. They may just both be happening for this person because of their vulnerabilities in other ways. And the integrated model does think that both disorders need to be treated simultaneously. This is an evidence-based practice. It has good research support, but it can be hard to find. So although this is the best thing you could refer someone to if they have both problems at the same time, it may not be something that's very easy for you to find, unfortunately. How can you apply the kinds of information that I'm telling you about to your work as a prosecutor? So what I'm going to talk about in this section is, first of all, how can you detect if a defendant has psychological problems? How can you manage a mental health crisis that comes up when you're working with someone? What sorts of legal outcomes are related to mental health and substance use issues, and what to expect when you're working with a defendant who has a mental health or substance use disorder. So first off, how do you know if this is a problem? One thing I want to make sure to mention is the issues associated with stigma about these kinds of conditions. So stigma is generally a negative belief about a group of people. So it could be a racial or ethnic group. It could be somebody from a certain country. It can also be folks who have mental health disorders or who have substance use disorders. And stigma, prejudice, and discrimination against people who have these disorders is something that is still a problem in our culture. And it may be especially strong in certain communities, especially some communities of color. So depending on the background someone is coming from, they may be experiencing general stigma about having these difficulties, and also this added layer of it being specifically something that's kind of not culturally appropriate for the folks that they're interacting with. Stigma can have negative effects on a person. So if you have a disorder, you already have some difficulties in life. And then if you feel like people are also judging you about it and looking at you negatively because of your disorder, that can lead to things like having lower self-esteem, having kind of reduced hope for the future, less feeling like things are going to get better for you. Your symptoms may actually get worse because it is stressful to feel like people are prejudiced against you or discriminating against you. You may have more difficulties in social relationships, work, and family domains because of the way people look at the problem that you have. And these folks may be reluctant to seek treatment or to stay in treatment because of stigma, because the idea of having to go to a counselor or having to go to rehab may be something that, they kind of don't want identified with them. So they're not seeking treatment because they feel like seeking treatment kind of makes them look bad. But of course, it's the only way that they're going to get better, probably. A survey done by the American Psychological Association showed that 20% of employees in the US said that they would be completely comfortable discussing their mental health with their employer. So their employer is in a position of power, and the majority of folks would feel like that is not a conversation that they want to have. They don't want to disclose any mental health issues to their employer. They don't want to talk about anything that maybe they need differently because of their mental health problems. And it's likely that that is the same case with the justice system, right? You folks are in a position of power as far as working with the defendant. And if they're not really willing to tell their boss about what's going on with them mentally, they're probably also not really excited to disclose that to the court or to folks who are going to be making legal decisions about them. So if you want to know if someone has a mental health or substance use disorder history, and this is something you need to be aware of, here are some recommendations for how to talk to them about that. So you want to avoid stigmatizing language. So, things like crazy, delusional, even though there are people who have delusions, delusional is kind of a negative label, saying that someone's nuts, and even saying that someone's an addict. That's a common term that people use to describe folks with substance use disorders, but it is a more negative way to talk about them, as kind of identifying them as like that their whole thing is just that they have a substance use disorder, they're an addict, they're not a person with a disorder. So that's not the best way to try to get somebody to open up to you. The same thing happens with mental health conditions. So it's best to talk about a person having schizophrenia versus being a schizophrenic, because that is that sort of labeling thing where we're saying that this is the main thing to know about you, that you have this disorder. It is also currently common to talk about folks having substance use and misuse as opposed to substance abuse. Abuse kind of implies that folks are making choices to do this and that it's something, that is under their control, when in some cases it may really no longer be under their control. And it's better to describe it in more neutral terms like misuse, as opposed to saying they are abusing a substance. Something that may work a little bit better than some of those things, but maybe isn't the best way to go, is just to ask somebody directly, do you have a mental health or substance use problem? And you may get an answer, but like I said, the majority of people feel like they don't want to tell their boss about their mental health problems, so they probably are going to kind of be cagey about trying to explain that to you as well. So the direct route may not get you the information that you want. So what I would recommend is to kind of ask around that question. So, have you ever seen a counselor or a doctor for things like feeling down, worrying a lot, or having trouble managing your life? Have you considered doing that, or have you wanted to do that? So that's giving them kind of like, have you had a treatment history for any kinds of thing? And it's not requiring them to say, oh, yes, I have this problem. It's saying that, well, I've had some difficulties and I talked to somebody. It's not quite as labeling. They may be a little more open to discussing that. And same thing with substance misuse. So, asking someone about their use patterns is certainly reasonable to do. And you can ask about whether this has ever caused any problems. And you don't have to make them kind of self-identify as being an alcoholic or something like that. You can just say, how often do you drink? Has that caused any problems for you? And then you can kind of assess whether it sounds like this is a significant problem without them having to really identify themselves that way. If I was doing a screening on somebody and I wanted to try to hit basically the main areas that would be of concern, these are the kinds of things I would want to know. If I didn't have the time to do like a full psych eval or whatever, you can still do some screening, or folks that you work with can do some screening to try to figure out if mental health or substance misuse is something that is important for this defendant. So those areas would be things like history of having symptoms or having treatment. So do they have any kind of background where they've been involved in the mental health services institutions or anything like that? Are they currently feeling depressed or anxious? Those are the two most common disorders, depression and anxiety disorders. So if I only had a limited amount of time and resources, I would at least ask about the most common things. If somebody has something like schizophrenia, that will probably be apparent for other reasons, but depression and anxiety are pretty common. So if you can kind of feel them out about at least having those common difficulties. I would also ask about current stressors. Are they going through a divorce? Did they lose a job recently? If they're having a lot of pretty intense, stressful life situations, stuff right now, that may put them more at risk for having mental health problems. I'd also want to know about their current substance use, so try to get a sense of patterns and things like that. If they're having any thoughts of suicide or self-injury, because as I mentioned, that is unfortunately not an uncommon thing for a lot of these folks. And are they having sort of daily functioning difficulties? Are they not sleeping well? Are they not, doing very well at their job currently? So maybe they won't identify that they're depressed or something like that, but for some people, it's more comfortable to talk about like, well, yeah, I haven't been sleeping very well. So they're having what in their mind is kind of like a physical issue. It may have an emotional basis, but if you find out that someone is not sleeping well or not eating well or not functioning in life, that at least gives you a hint that there may be some mental health background there. When you're trying to talk to somebody about these difficult things, you want to use good communication skills so that you're getting the best information and having the person feel kind of the most comfortable talking to you about this. So that would be things like speaking slowly and clearly to ensure that they understand them, not using a lot of jargon. People have obviously different levels of experience with things like mental health problems. Their education level may be quite a bit lower than yours. So you want to not be too technical when you're talking to them. You want to clearly explain what is happening, what is going on with their arraignment or their trial, what is needed from them. Do they need to go make an appointment for an eval or for therapy? It can be helpful to ask them to confirm that they understand you. So like, can they repeat back what is needed from them at this point? And then you can check to see if they've really gotten the information in. If you're going to ask someone to do something like it appear at a future date or attend a therapy appointment, it's helpful for you to jot that down in a written form because the person may be kind of uncomfortable discussing this with you. And so they're maybe not remembering everything completely because they're kind of freaked out during the conversation. So it just takes you a couple seconds to write down like, okay, here's the address you need to go to and you need to go next week. And that way they have it written and are able to refer to that. And that increases the likelihood that they'll follow through. In general, you want to have a problem-solving approach. So you are trying to be helpful, you're trying to make sure you understand the situation, and even though you're a prosecutor, try to kind of avoid coming across like you're trying to punish them, you're trying to make them, deal with the consequences of their actions. You'll get more traction with them and have a better working relationship with them if you're saying, look, like I'm trying to help you deal with some of the issues in your life and solve problems better. Things that you want to watch out for as far as being kind of concerning behaviors would be things like odd or inappropriate behavior. So, are they not dressed right for the climate? I mentioned that earlier. Are they seeming like they're kind of responding to stuff that you can't see or hear, like they might be hallucinating? Are they saying kind of strange things to you about people who are trying to harm them? Anything that's bizarre like that is definitely something to pay attention to. The person may also appear to have a mood difficulty, like they seem like they're really sad or down, or they seem a little too high-spirited, like they might be manic. So you can kind of watch their mood and see if it seems appropriate. If someone is disoriented, like they don't really understand why they are in the situation, where they are, what your job is in relation to their case, that suggests that they may be having some mental health issues that are making them kind of confused and not in the best condition. They may have gaps in their memory of events that led to them getting arrested or having the difficulties they're having currently. That may be mental health related. Lots of people in the justice system are going to be kind of disrespectful or maybe belligerent to law enforcement or to folks in the courtroom. So that is not on its own, like definitely a sign of a mental health issue. But folks who have mental health issues may behave more inappropriately like that because they're, irritable or becoming kind of aggressive because of their symptoms. So that can be a clue. If it seems like they're kind of not really paying attention to their proceedings or they don't really take the situation seriously, that may mean that they're not super connected to reality and they're not making good decisions. If they don't make very good eye contact, that may be a sign. If their mood and emotions seem to be kind of all over the place while you're talking to them, that suggests they're not regulated very well. They may have a mental health issue. If they speak too quickly, they could be manic. If they speak too slowly, that could indicate that they're depressed or that they're having some other major mental health difficulty. And of course, if they talk about hurting themselves or somebody else, that is something to take seriously. So if you have folks that are doing any of those behaviors, that suggests they may be on their way to a mental health crisis. So what do you do when you have a mental health crisis? Okay, yeah, I see Scott's comment. So as prosecutors, you're not allowed to speak to the defendants. You communicate through the attorney. So yeah, so this may be a conversation that you're not personally having with folks, but it still is the kind of information that you would want to get. So this could happen where you might be in a mental health crisis situation with somebody when you're not really expecting to be, and it definitely isn't like a regular part of your job, but this can still be useful information for you to have, just so you sort of know how somebody should deal with it. So a mental health crisis is when someone is having extreme difficulty with a personal problem, an event, an interpersonal situation, and it may be that it's substance induced. So, they may be high or drunk while they're having this crisis, and so they're not really thinking clearly. Could be related to a mental health disorder, or it could be just sort of general lack of coping skills for dealing with life's difficulties. Crisis events can involve family difficulties, obviously intoxication. It could be where someone is talking about harming themselves. That can be a mental health crisis. There could be a physical or sexual assault against somebody because they're not really thinking clearly about what's going on. Oftentimes it is hard to talk to somebody who is in a mental health crisis because they're really not thinking clearly. So they may be fearful about things. They may not be concentrating very well. They may seem kind of agitated, and their judgment is not going to be the best. So it may be hard for you to deal with them, but I'll give you some tips for how you can potentially deal with this if you do run into a mental health crisis. So what you want to do is called de-escalation. This is moving somebody from a state of high tension and agitation to a state where they are not so distressed. Your goal is to help them regain control of their emotions and resolve or at least reduce the situation that is causing the difficulties. So what you want to do includes things like active listening, so acknowledging that you hear this person and making them feel like you are listening. Using I statements, so I hear that XYZ happened, as opposed to always talking about what they're doing and kind of putting it all on them. Restating their statements can help, so kind of they'll explain to you why they're so upset, and you can say back to them a summary of that and kind of give them an indication that you've heard them and understand the details. Mirroring or reflecting is when you say the exact same thing back to them, so using their language or making sure that you have communicated that you heard exactly what they said and you understand it the same way they do by saying the same thing back to them about why they're upset. And then at the end of a conversation like this, it can be helpful to do a little bit of a summary or paraphrasing so that you make sure that you've gotten all the information right and also that they feel like they've been heard. So that could be something like, okay, you've explained to me that you came home today and your parents told you that you can't stay at their house tonight because you're intoxicated. And you're really angry that they're not letting you stay there and you don't know where you're going to spend the night. So that is why you're so upset right now. So a few sentence kind of summary of what may have been a much longer conversation where you're hitting the high points of what they've tried to explain to you, and you're able to both confirm that you understand it and confirm with them that you've listened to them and are taking their concerns seriously. Things that you want to do when you're trying to de-escalate would be to ask a lot of questions, make sure that you understand what it is that they are distressed about, what it is that they want out of the situation. You want to try to remain as courteous as you can be. It can be challenging to work with someone who's in a mental health crisis because they're really not their best selves right then. So they may not be very courteous toward you, but it is not going to help things if you are not trying to be fairly polite and respectful towards them. So as much as possible, try to be calm and courteous when you're talking to them. It's helpful to make it clear that you want to understand them and you want to help them. One way to do that is physically with kind of an open body posture. So, try not to physically intimidate them. Don't just kind of sit there with your arms crossed, scowling at them while they're talking. Make it look like you are listening to them, you're nodding along, you're interested in understanding their side of things. You don't want to necessarily stare them down during this situation, but being able to make some comfortable eye contact throughout the conversation usually helps people feel like they're being listened to. So that is something to try to do. Again, not 100% of the time, but try to make eye contact while you're talking to them. And you want to just remain calm, speak slowly, and use short sentences on your end. They should be doing most of the talking. You're just kind of confirming things and following up on things that they have said and not doing the majority of talking while they're in this distressed state. Things that you don't want to do would be to ask why they're reacting like this. Like, well, I don't know why you're so upset about this. Why are you making a big deal out of this? That's not going to help them calm down. So you can acknowledge that they are reacting in a way in your mind that seems a little inappropriate for the situation. It is not helpful to tell them that. So you can just understand why they're upset, and you don't need to understand exactly why they're doing the specific stuff they're doing. It's also not helpful for you to raise your voice. They may have their voice raised, but if you remain kind of calm and speaking at a normal tone, hopefully they will come down to that level. If you start raising your voice, that is unlikely to de-escalate things. You don't want to rush through this kind of conversation. It can take a little while for someone to calm down. So it's not something you can always do in a couple of minutes, but it needs to kind of go through the whole thing for it to really be a stable thing where they're going to be okay afterwards. You also don't want to take things personally. As I mentioned, folks are agitated. They may be saying things that are not terribly kind or helpful, but they're in a bad situation right now. So it's helpful for you to just understand that, okay, this person's having a crisis. They're saying things that are not very nice, but I'm not going to take that personally because I'm not in a crisis situation and I can be calmer and try to help them through this. If you're talking to someone who is psychotic and they are having hallucinations or they are deluded about how people are out to get them or whatever, it is not helpful for you to challenge that. So you know that that's not the case, right? Like God is not talking to them through the radio and telling them to do stuff. Like you're not hearing that. That's not a real perception. But trying to argue with them about that is not going to help them calm down. So you can just kind of ignore any psychotic symptoms that are coming up in their description of what's going on and try to focus on the things that you really can help them with, like how they can cope right now, how they can make different decisions in the moment so that they can resolve this situation. If you have somebody in a crisis situation, there are a number of resources available to call. So in Texas, the MHMR has a crisis hotline that is available throughout the state. There's also the National Suicide Prevention Lifeline number that I gave you guys earlier. That lifeline also has a veteran-specific crisis line. If they call and they press 1, or if they want to do it over text, there are specific veteran-related suicide crisis things. There is a crisis text line that is available if you have a defendant who would prefer that. Your county mental health agency may have their own crisis hotline. On the Health and Human Services website, there is a listing of counties that have their own local crisis hotlines. That may be useful. 211, which is kind of informational resources, can help as far as getting somebody connected to services that may exist, but they're not an active crisis line. So that's not an emergency call to make, but it may be useful. And then beginning in July, across the US, we will have 988, which is the mental health crisis version of 911. So starting next summer, you will be able to call essentially 911 type number for a mental health crisis. That does not exist yet, but we do still have all these other resources. There may be a couple other things that are available in your area depending on the resources. So law enforcement may have a crisis intervention team. These are specially trained law enforcement officers who have been trained on how to de-escalate situations and connect folks with treatment. There may also be from a mental health facility a mobile crisis outreach team. So this would be staff that go out to provide psychiatric emergency care in the community setting that can be called when there's a crisis situation happening. And you may have mental health deputies who are a different form of specially trained law enforcement officer. In general, if these things are available, these are the folks to call to help you with a situation like this. Calling police officers who are not crisis management when you have the option of folks that are is less helpful because they are not trained to deal with this kind of thing. So if you have the option of one of these things, I would call them first. But obviously in some cases, you just need to call the police, and they don't always have, like not every county has law enforcement officers that are specially trained and everything. The outcome of a mental health crisis is a few different kind of levels of outcome. So at the first level, the person calms down and does not need immediate intervention. So you're able to resolve the situation. They do not currently seem like they are a danger to themselves or anybody else. They can go on their way. The next level would be that it does seem like they need to be evaluated by a mental health professional soon. That it doesn't really seem like they're totally okay. You're not sure if they're going to stay okay. Maybe then you can connect them to services so they can get into therapy or they can get on medication so that this kind of thing doesn't keep happening for them. The third level would be that they really need to be seen by somebody today. They're not all the way calmed down. You do not think it's necessarily safe for them to go. In that case, they may need to go to the emergency room or to a psychiatric hospital to get evaluated by professionals on that day. And the last level is when the person really is not even close to regaining control of their behavior and may not agree to go to see a hospital. So at the third level, if you can get them to agree to go be evaluated at the ER and, like a family member can drive them or whatever, great. If they'll do it voluntarily, that's great. At the fourth level is when the folks really won't volunteer for that. So if necessary, they can be mandated to go through that process, and they may need to be held against their will, and they may need to be transported by law enforcement to get an eval for their current mental health crisis. So a few legal outcomes that sometimes come up for folks with mental health or substance use disorders that I'm sure as prosecutors, you guys are pretty aware of these things, but just to give a quick overview. So obviously competency issues do come up with folks who have these disorders. The typical profile of someone who is found incompetent to stand trial is that they have one of our more severe and impairing disorders here. So that would be something like schizophrenia or a very severe cognitive impairment where their IQ is very low, things like that. That is who most often is found incompetent. These are folks who really cannot understand the charges and can't participate in their own defense, and it's not going to get better because of the nature of their condition. Competency restoration is an option that is available where folks who are currently at their hearing or whatever are not seeming like they're competent, but if they get treatment, they may be able to be competent to stand trial down the line if it's a condition that can be treated effectively. Now, if they have an extremely low IQ and are intellectually impaired, there's not really a treatment for that, right? We don't have meds to improve their IQ. So that kind of person probably is not going to get restored to competency. But if they have schizophrenia or bipolar disorder, they might be psychotic during their arraignment or whatever, but they can be treated. So somebody can go to an inpatient forensic unit where there are various kinds of therapeutic activities, maybe medication for them. And the majority of folks who are referred in that manner are restored to competency. 81% are able to be restored to competency within about 3 or 4 months. And then they can proceed with the legal proceedings that they need to do. Some folks may be found not guilty by reason of insanity, by either plea or verdict, that they were mentally disturbed or they were otherwise incapacitated at the time of the defense. So they didn't really have the intent required to commit the crime. An example with a mental health related disorder would be they assaulted somebody because they believed that person was possessed by the devil and were going to harm them. So that person, was not in their right mind when they committed that. They were having significant psychotic symptoms that led them to be aggressive. And it could be the case that it's determined that they're not really guilty because the psychotic symptoms were influencing their behavior so much. Voluntary substance use is generally not a reason to get not guilty by reason of insanity. So if they were just high and they behaved inappropriately, that may not be an outcome for them. Could be diminished capacity, but may not be a way for them to kind of totally get not guilty out of the situation. But with psychotic symptoms or other major mental health things, they may be found not guilty by reason of insanity. So we had a poll question about court-ordered treatment. So a little more information on that. People who are offenders may be appropriate for mandated treatment. Many people who are in substance use treatment particularly indicate that legal pressure is kind of how they got in the door in the first place. They had a DWI or they had some other kind of, possession and other reasons why they kind of got on law enforcement's radar. And they got forced more or less into treatment, but then are able to actually benefit from that treatment. For folks who are less severe and maybe don't need to go into like an inpatient rehab kind of setting, you can still facilitate connecting them to voluntary treatment resources that they can access in your community and less intensive interventions. So things like drug education classes, self-help groups, that may be appropriate for folks when like mandating treatment is not really an option that makes a lot of sense to you, but they still would benefit from those kinds of services. And to answer the poll question, research actually shows from NIH shows that outcomes for people who are legally pressured to enter treatment are as good or better than outcomes for folks who voluntarily attend treatment. And I know why majority said that they didn't think this would be the case, because it surprised me a little bit too. You'd think if someone is agreeing to go to treatment, they'd be more motivated than folks who aren't. But the idea behind the study was that when folks are legally mandated, they have more on the line, right? So they're attending more frequently. They're not just like skipping sessions, because if they do, they get in trouble with their PO or whoever. And they're staying in treatment longer too, because they are mandated to go. So they can't just quit partway through it or there's legal consequences for them. So it seems like that increased engagement in treatment, even though they're being forced to do it by the legal system, actually does help them benefit more from the treatment process. So if you are mandating folks to treatment for substance misuse or mental health kinds of issues, it is not the case that that is worse for them than if they volunteered to go. It's still not the easiest process, but they can definitely benefit from that. One of the reasons why treatment is helpful is that offenders who have mental health or substance use issues have other problems in their life. They don't have just this one thing. They may have family problems, their social skills may be limited, they may not have completed much education, they could have trouble holding a job, they may have medical problems. Treatment in a behavioral fashion can help them address these things. They can get better communication skills. They can figure out, ways to get more employment opportunities. Like, do they need to get additional training or whatever? A therapist can help them navigate their life a little better so that they are more functional and better adjusted and able to move forward in a positive manner. In general, longer treatment may be indicated for people who have severe problems, so some of the more severe conditions, or when they have multiple problems, like they have both a mental health and a substance use issue. For substance use treatment in particular, it is recommended that folks do an inpatient treatment for at least 90 days. And that is not always super available, and it does depend on insurance and things like that. But drug relapse is really common, and multiple episodes of treatment may be needed until they kind of get enough dose of the treatment for it to really benefit them. So if it's at all possible to get somebody into treatment for at least 90 days, they're more likely to, out of the gate, have better outcomes than if they do like a few 28-day stays. So what can you expect when you're working with defendants who have mental health and substance use issues? So unfortunately, these are more complicated cases to work with. Mental health and substance use symptoms can interfere with somebody's compliance. So if there's requirements for them to stay employed, for example, that may be more challenging for them than folks that don't have these difficulties. They may not be as reliable as far as showing up to appointments that they need to do because of various life complications that they have and symptoms that they're experiencing and things like that. They are also more likely to recidivate, so they may not be compliant because they're continuing to engage in criminal activity. And many of these mental health disorders are chronic. So this is not a situation where you refer them to treatment and then they get fixed. They may continue to have these problems over the long term. They may come in and out of your office for a long period of time. As far as substance use disorders, the risk of relapse continues for months and years after treatment, unfortunately. More than 2/3 of folks relapse within weeks or months of starting a treatment program for substance misuse, and more than 85% relapse within 1 year of treatment. So we do have treatments that have been found to be effective, and the majority of the time, one course of substance use treatment is not going to totally fix someone's problems, and they're going to continue to use and continue to probably come through multiple treatment programs. Things that we notice in treatment for folks who have mental health and substance use issues who are also justice involved is that sometimes we have folks who have difficulty being compliant with their medication. So they decide they don't want to take it every day or they don't need it anymore. So that can make treatment harder if they're not taking the meds that they need to. Attendance at therapy can also be not terribly compliant. Sometimes this is willful, like they don't want to be in therapy, so they're not showing up. Sometimes it is because of life complications. So they don't have reliable transportation, they don't have childcare, things like that. Things that are sort of clinical profiles of folks who are justice involved are things that are associated in the treatment literature as being not as positive indicators for treatment outcomes. So that would be things like antisocial traits, being more impulsive, being more aggressive, having a substance use issue, and having generally kind of a difficult interpersonal style. So if I just had a group of clients and I didn't know if they were justice involved or not, these are the kind of things I would look for to see how likely it is that the person is going to be able to benefit from therapy and successfully complete any kind of therapy program. And we know that these traits are all kind of more common in justice involved folks. So as a group, this is a harder to treat population than folks who have a mental health disorder but aren't justice involved. So as folks have identified, clearly we have difficulty finding services for people who need mental health services in Texas. And this is not just Texas, this is also true in Mississippi, it's true in a lot of places. So a couple places that, again, you may be aware of this, but just to make sure everyone's aware of all the options. So the state health department does have a website where they list different kinds of community mental health providers and things like that across different counties that you're working in. There is, in terms of just general types of services available, community mental health centers are publicly funded places. There are often some master's level folks, probably some psychologists, and probably some medical care as well. And they will take a lot of folks who have Medicaid or do not have insurance, as well as folks that do have insurance. This is the setting where I did my residency in a different state in New York. But community mental health centers like MHMR kinds of places are a option for mental health services. There's also, of course, hospitals for folks that need to be in inpatient settings. There are private practices. I recognize that a majority of folks that you work with who are justice involved are not going to have the insurance or the money to see a private practice for therapy. But of course, you can try to work out a kind of agreement with a private practice to see some folks if that's something that's available in your community. And then lastly, I like to mention to folks the existence of training clinics. So when students are training to be mental health professionals in counseling and psychology like me and a few different kinds of disciplines, they do need to get some hands-on work while they are in their graduate training program. And that is often a way to access low-cost services in the community because it's students, not licensed professionals, and they're supervised by licensed professionals. But there may be, if there's a university that is near your jurisdiction where they have a training clinic on campus, or they have some sort of programming where you could get graduate students who are in training to provide mental health services. Now, this doesn't change the inpatient issue, right? So if you have folks that are waiting for a hospital bed and that's what they need, this doesn't help with that. But if you have folks who could benefit from outpatient therapy, being able to go through a university and getting students to provide those services is often a high quality level of service because it is supervised by the faculty members who are experts in this kind of thing, but it's also low cost. So that is something to be aware of if you have universities in your area. And then I want to just sort of note that, like Mississippi, Texas has a number of mental health professional shortage areas. So the photo on the screen here is from the federal government, the designation of all the counties in Texas that are mental health professional shortage areas, meaning that there are not enough licensed mental health professionals for the population. And that is most of Texas. So some of you guys are coming from those counties. And it is, if you're not in, like Dallas or Houston or something, it is going to be hard for you to be able to get your folks into care because the number of professionals is too low. So one thing to be aware of is that telehealth may be helpful for folks who can be seen on an outpatient basis. We have a lot more telehealth now than we did before the pandemic because everyone kind of had to pivot their whole lives to doing stuff like this through WebEx and Zoom and stuff. And specifically, both Texas A&M and the University of Texas in the Rio Grande Valley have telehealth clinics where they will see folks who are anywhere in Texas. The way that licensing laws work is that if a counselor or a psychologist is licensed within the state of Texas, they can see someone anywhere in Texas. It does not have to be in their local town. It does not have to be in person. They cannot see people from Oklahoma or Louisiana because there's rules about you have to practice in the state you're licensed in. But if the client is in Texas and if they have the ability to do, Wi-Fi, if they have Wi-Fi and they have a computer or they have a phone they can work on or whatever, it may be possible for some defendants to be able to get that outpatient level of care remotely if they're able to work with one of these clinics. And these are both training clinics, so these will be low cost services, but there also may be other practices and things in various areas throughout the state where you could get folks hooked up with services. And importantly, the one in the Valley is, they provide services in both English and Spanish. So if you have folks who need to be seeking outpatient services in Spanish, they are a good option for that. And if you want to just generally kind of expand your work with mental health professionals, a few ways to do that would be, number one, to try to figure out if there are some places in your community that would accept your referrals on a kind of ongoing basis if you have a lot of them. So are there practices? Is there a hospital? Is there a community mental health center where you can build a relationship so that you're not having to be on the extremely long wait lists that folks sometimes have? You may be able to talk to folks that are in administration there to kind of get some of your folks fast tracked if they are anticipating that they'll get a significant number of referrals from you, because obviously it's kind of a business situation. So they want to make sure that they are able to cover all their expenses, but you may be able to get some priority referrals. You also can ask mental health professionals to consult with you. So for example, currently I work with one of the local juvenile drug courts, and I'm a consultant on their project and doing some data collection and doing some evaluation to try to help them maximize the services they are giving and improve the situation to help the juveniles that are in that system be more compliant and have better outcomes. If you want to try to write grants to get additional state or federal funding to try to provide mental health services in your community, mental health professionals in your local area may be willing to work with you on that and contribute to that grant writing process. And then lastly, there's student training opportunities. So I mentioned training clinics, but you also may be able to get an intern in your setting. So I mentioned that I worked in, I was in Brazos County doing community supervision mental health clinical services. And I was also in Grimes County doing that when I was in graduate school. And so that was basically like my job during grad school is I went and spent 20 hours per week in each of those offices and provided services to the probationers that were needing an evaluation or counseling. And the university, like the probation office paid the university so that I then got my graduate stipend that you get during graduate school. But it's lower cost than if they hired a full-time mental health professional. So you may, if, again, with a university in your area, may be able to get some student training opportunities so that you could get some additional mental health services in your local area.
As Dr. Charles just mentioned, a few referral options to DWI defendants who need outpatient services. I would like to add a few more with you until we're almost done with this training. So we just talked about the importance of talking to the legislative and adding resources because we have a shortage of resources. And one way we can walk towards that direction is being part of this initiative that has been started by the Substance Abuse and Mental Health Services Administration. So SAMHSA has developed the sequential intercept model, which is basically a mapping of how individuals go through the criminal justice system. And this mapping is basically trying to identify resources and gaps in communities and try to see at each intercept what kind of local strategic partnerships could be created. And this is one of the initiatives that the Judicial Commission has been doing. I think Courtney, our program coordinator, just shared a link in the chat with you. If you want to take a look at what she has just shared, we'll also add that to your handout. But basically, this is trying to understand what does your community have as far criminal justice resources and also mental health resources. And once you identify what you have, what's missing, that is a conversation that you can bring this information to your legislative and have some data to back up what your needs are. I also wanted to share with you a couple of examples of jurisdictions that have been trying to curb recidivism by implementing pretrial practices and trying to connect WI defendants with the mental health community. And the first example I have is a success story of setting conditions of bond in Santee County in Minnesota. They have this pretrial program called Remote Electronic Alcohol Monitoring. And this program is for repeated WI offenders. So basically the magistrate judges and the attorney's office agreed that they would either sentence the WI defendant to choose either maximum bail or to participate in this program and promise to appear. So, for example, the defendants who decided to post maximum bail wouldn't be required to participate, but if they decided to do so, they would have received the agreement to be released on a PTA. The second example I wanted to share with you is one that's being done by rural counties in South Dakota. They have implemented this project that's called 24/7 Sobriety Program. And these programs are basically created for DWI folks who need supervision. So they would need drug testing, interlocking, transdermal monitoring, but they have low clinical needs. So they might not have a substance use or a mental health issue. And these are two types of pretrial promising practices that you will potentially see coming down to Texas and you might want to pay attention to. And both of these programs have implemented some type of referral system for the defendants. And lastly, I just want to point out that some of you already might have an established relationship with your local mental health authority or your jailer. Both of those resources can provide you with the screening and assessment results that you might need to identify the WI defendant's needs and know their past treatment history information. And a second resource I wanted to share is the Brief Intervention and Referral to Treatment, SBIRT. And SBIRT is an approach to deliver early intervention and treatment services for persons with substance use disorders. So you can ask the defense attorney if the defendant has received this type of intervention, or you can figure it out if your community has a provider. And it is likely that you have a peer support group or a traffic safety coalition that are eager to provide those services. Those resources are all shared in the handout, by the way. And we share all of this because we don't know if you're a part of a pretrial diversion program or if you're part of the WI court. And the resources that Dr. Noor mentioned to you like the potential university partnerships, the local crisis units, the telehealth options. Those are resources that you can potentially pursue to make your program more robust, right? And lastly, if the defense attorney claims that there are no options for WI defendant, you can always tell them to call or access the United Way website, and that's the state hub for all the available resources in the community, and that way they can choose to seek the resources on their own. And it's important to make the distinction that we showed a bunch of resources that could be very helpful to the DI defendants that are in an outpatient setting, and we are aware of the limitations of the inpatient availability, and that's why I mentioned about the Judicial Commission. They are working on that aspect for the state. But to close today's training, I wanted to leave you with a few thoughts, and I'm aware that we don't take the Blake statement that most people self-correct. We know that there's something more behind a person who keeps doing the same crime despite of all consequences, right? So as of today, we know if they keep doing it repeatedly, they usually have something that prevents them from making the right choice, or at least planning to make a plan before they drive impaired. So, and the interventions that we have in place are usually set up for the low risk or who needs a defendant, right? The regular sentence or the regular probation that is done by a FAR. Those are for the individuals that have been identified as that fourth quadrant that we talked about earlier. And that's why I harp on the point of having the DWI validated tool, because depending which quadrant the defendant falls in, there are other options other than inpatient option that we think about most often. And that's why we wanted to expose you to all of these other resources that are potentially available. On behalf of our team, we appreciate and we're grateful that you spent this time with us. I hope you have a great rest of your day, and please let us know if we can be of any help to you.